Now at this stage there are major differences in terms of what the surgeon's going to do in terms of putting an acetabular component in. And the two differences are whether putting a cementless acetabular component in or a cemented acetabular component. And the surgical techniques are quite different. With a cementless acetabular component, the surgeon has to create what I call a woodworking fit to the bone. It makes a very precise shape. It's normally about 1 millimetre undershape to the implant. And common-sized uncemented implants have an outer diameter between 52 and 56. So the surgeon would make a reaming between 51 and 55 for common implants. But of course there's huge variety around this. So quite simply the surgeon's created a slightly undersized, checks it with various trials. Once they're happy with the size, the actual implants taken into theatre and placed accurately into the pelvic bone. And on top of the liner, which is normally made out of titanium, the shell is put in, which is made out of titanium. A liner is put in, and which is the bearing. And this can be made out of a variety of materials: titanium, ceramic, cross-linked polyethylene, or even metal on occasions. Now, if a cemented implant's being used, the technique differs because you don't want to get a very smooth fit between the plastic sockets and the cement. You want to make a much more complex structure, more like this, in a way, the surface of the moon with craters in it, and keyholes, so the cement can actually key through into the subchondral plate in the bone. So, although it is reamed, the surgeon will then create multiple drill holes into the bone, so that when the cement's put in, it can be pushed through into the interstices of the cancellous bone structure. And the bone is cleaned and dried. The acrylic cement is mixed in a mixing system. And there are different types of cement, but quite commonly, if the cement's received around about the 2-minute mark and put into the acetabulum around about 2.5 to 3 minutes, depending on surgical preferences, temperature, viscosity characteristics. The cement's put in, and the cemented component isn't put in straight away, but the cement's pressurised with a special device which pushes, sort of a rubber seal that pushes the cement into the cancellous bone structures. You get this really good mechanical interlock between the acrylic cement and the bone. Having removed the pressurizer, the actual implant is put in later on, normally around the 4-minute mark, when the cement is actually achieving quite a high viscosity. And the cemented implant's held carefully by the surgeon until the cement sets. And the common setting time is around about 10 minutes. It's rather like super glue, that it starts off quite putty-like and then firms up. Although I should say that it isn't glue, it's a grout. And that's a quote from Sir John Charnley. It has a different characteristic. It's not an adhesive, it actually is a filler, and it fills into the cancellous bone and makes a very good interlock for the acetabular component. Now, having positioned the acetabular component, work then commences on the femur. So the retractors come out of the acetabulum, the femur is then rotated round, so the surgeon can get access to the femur through the same incision using a window type approach to gain access. Having gained access to the femur, the femoral shaft is then accessed using a variety of instruments to open up the femoral canal. And again, there are differences between preparation for a cemented or a cementless implant. First of all, a cementless implant. And this is normally fairly straightforward because, like the acetabulum, the surgeon's trying to create a very accurate woodworking shape, about 1 millimetre undersized for the eventual component. And they do this purely so the bone will expand as the real implant comes in, and it's an elastic type of fit. So, having reamed down the femoral canal, a variety of dummies or trials. When I say dummies, I don't mean the surgeon's a dummy, I mean the instrument is like a dummy of a prosthesis to make a shape, an accurate shape, replicating the real implant. And of course, the surgeon has knowledge from the template or the computer graphic about what size it's likely to be. 10 millimetres, 11 millimetres, 12 millimetres in diameter, and what sort of offset it has, high offset, low offset. So, having been satisfied with this, the trial is inserted into the femur, and the femoral head is attached to it, and the surgeon then takes the hip through a range of movement to satisfy the stability and length. And it's very important that the limb length is checked at this time. There are a variety of techniques to do that. And having satisfied the surgical equation, if you like, at this stage, the trial is removed from the femur, and the surgeon then takes in the real implant, and the real implant is put into the bone, and the femoral head is attached, and the hip is then reduced. And hopefully, or definitely, the hip should be the same as it was in the trial position, so there are no nasty surprises. And of course, if for any reason the trial is unhappy, then adjustments are made at that stage before obviously the hip replacement is reduced. Now, having put the hip replacement back in, there's a matter of closure. And this is a really important part of the operation, meticulous closure of the wound to make sure the wound's well sealed and all the muscles and structures are put back together. Quite commonly with the posterior approach, the external rotators and capsule are attached to the bone using intraosseous holes or drills through the bone to get firm attachment to the bone structure, because otherwise it's very, very difficult to get soft tissues to stitch back to bone. So you have to stitch it through the bone. And having got good closure there, that provides a good tissue structure posteriorly, which assists stability. And research suggests that by having this sort of this sort of repair can sort of halve the dislocation rate, or even reduce it further than that. Having reduced the external rotators and capsule, most surgeons may want to repair the trochanteric bursa, but there's a variation on this, and whether the surgeon actually tries to repair the quadratus femoris, if indeed that's been taken down, is also a matter of controversy. The deep fascia is then closed, usually with a continuous stitch. Drains now tend to be going out of fashion. 10 years ago we used to routinely drain hips, that is, put a tube into the wound and allow any excess blood post-operatively to form in a bottle or a similar device. But again, we're moving away from drains because we're finding that there's no real evidence that they're more effective. And drains theoretically can have some complications of their own right. So we're moving away from drains. Then the fat layer is normally approximated, and then the skin, either with clips or a running subcutaneous stitch, depending on the surgical preference. Now, having got to that stage of the operation, if the operation has been carried out with a spinal anaesthetic, I mean, you should feel absolutely fine. You still can't feel your leg, and most patients are really surprised that it's all really come to the end of the operation. It's almost surreal. Having put a dressing on and taken you off the operating table onto your bed, you then move for a short period of time into the recovery area. The recovery area is an area of almost post-operative high dependency, where there's a dedicated nurse to look after you in this immediate post-operative period over the next hour to make sure that there's no bleeding problems, the blood pressure and pulse are okay, you feel comfortable. Sometimes an x-ray is taken at this time, but not always. And once everybody's happy that you're fine, you're well, and there are no issues, you'll be transferred back to your ward or your room for further observation.